all who are gathering the endometriosis awareness program presented by Endotone from Charakpani. It is my distinct pleasure to introduce our esteemed guest speaker for today's webinar, Dr. R.G. Patel, MD Gynecology, Senior Infertility and IVF Specialist with 20 years of experience in IVF. Director of Sunflower Women's Hospital at Ahmedabad, which is a FOXY recognized infertility training center. Dr. R.G. Patel has trained more than 400 gynecologists, delivered more than 20,000 IVF babies successfully, published various clinical research papers, presented oral and poster presentations, delivered many lectures at national and international forum on IVF and infertility. He was selected as one of the members of expert committee at the Central Board for ART and Surrogacy Regulation Act 2021 at Central Ministry of Health and Family Welfare, New Delhi. He holds the position of President, Gujarat Chapter, Indian Society for Assisted Reproduction from 2024 to 2026. He is the member of European Society of Human Reproduction and Embryology as well as FOXY. He has pioneering work in male infertility on microtessa with special interest in repeated IVF failures. Through his career, Dr. R.G. Patel has been awarded Best of Best IVF Center in India by India Today Group and Bharat Ke Ratna Gujarat Se Award in 2023 by Smriti Irani. With his extensive expertise in IVF and infertility, Dr. R.G. Patel brings a wealth of knowledge and insights that are invaluable to our discussion. With this note, I hand over the session to you, sir, Dr. R.G. Patel.
Good evening to everybody, and good evening on the day of IVF day. I hope you will be well in your health and happiness. Today we will discuss very important topic about the endometriosis. And endometriosis affects from adolescent to menopause. And for that, we have to understand about the endometriosis, why it happens, how to diagnose, how to manage it, and what are the probability of problem in menopause also. And what is the new advancement for the treatment of this endometriosis. As we know, endometriosis can cripple the life. Endometriosis can cause severe pain before and during period, heavy and abnormal bleeding, suffer, often avoid work and social function because of acute pain. They also find it tough to conceive. And what is the endometriosis? It's a benign condition in which endometrium gland and stroma present outside the uterine cavity and wall. And tissue is like a endometrial tissue morphologically as well as functionally. And this respond to hormones cyclically. So this is a estrogen dependent condition. Around 5 to 20% endometriosis incidence during the reproductive age. Those who are infertile, about 30 to 40% are because of endometriosis. If you see in India, around 26 million people are suffered during the reproductive age. And 5% girl below the 18 are suffering from endometriosis. They have dysmenorrhea, pain, and required care of this young age girl. Now, why it happens? There are endometriosis known as the theory, so many theory and disease of theory. One theory is Samson theory. That is a menstrual regurgitation, and after regurgitation from the fallopian tube, it implant on the ovary and peritoneum. So it's a retrograde menstruation. Fragment of endometrium will transport to the peritoneal cavity through the tubes. And the cells, that is the stem cells, will implant on the peritoneum and it will grow. There is a neovascularization and the inflammation, and there is the obstetric, because sometime in young girl, if you see, so maybe because of there is an obstruction in outflow of the menses, like cervical stenosis, maybe septum, maybe vaginal septum. So that obstruction in the genital tract leads to a retrograde menstruation and leads to endometriosis. One more theory is coelomic metaplasia theory. That is a coelomic membrane transformation into the endometrial tissue. So a site other than pelvics, which explained by this coelomic metaplasia. Sometime these endometrial cells or stem cells will travel through the lymphatic and vascular away from the pelvis, and that create endometriosis in kidney, in umbilicus, in vaginal lymph node. So that is the lymphatic or vascular metastasis theory. And genetic 7 times more in second generation, third generation, because previous history of endometriosis in your parent or relative. So genetic also one of the factor. This is new theory like immunological factors. Reduce clearance of endometrial cells due to the decreased NK cells activity or decreased macrophage activity. And this is inflammation. Endometriosis may be associated with some clinical peritoneal inflammation. So all leads to endometriosis. Why there is a endometriosis? This is a disease of theory. Most common is peritoneum, ovary, deep endometrium, around the uterus, around the fallopian tube, around the ovary, but may happen in the rectum, intestine, maybe deep vaginal septum or bladder, maybe a scar, maybe umbilicus. So all the common site for the endometriosis. If you see type of endometriosis, maybe pelvic, extra pelvis. It is a pelvic, then maybe peritoneal, maybe ovarian, or maybe deep infiltrating. If see the extra pelvic, then GI, maybe urinary, maybe scar, maybe vagina, maybe thoracis. Even we have seen from brain also, endometriosis. The most common presentation is pain. This is a dysmenorrhea, dyspareunia, deep-seated pelvic pain, and around the menses, before it will start, continue during the menses, and stop slowly after menses. If you see the pain during dyspareunia, lots of patients we have seen, there is a dyspareunia, they have not kept a single time relation after 3 year or 4 year or active married life. And this dyspareunia, that marital life is very much disturbed. That is because of deep dyspareunia, because of fixed retroverted uterus. All endometriosis may involve in the peritoneum, uterosacral ligament, rectovaginal septum. Sometimes there is a dysuria or dyschenia because of extragenital endometriosis. And also abnormal bleeding, premenstrual bleeding, heavy period, maybe clots with pain, polymenorrhagia, menorrhagia, and it will disturb the quality of life. Again, yes, infertility is very much 30–40% suffer from the infertility. And because of advanced disease, there is adhesion, fixity, result in structural damage of tube and ovary that will impede the tubo-ovarian mobility. If you see the ovarian function, then anovulation, luteinized and ruptured follicle, and quality of oocyte may hamper. That oocyte maturation defect leads to decreased fertilization, decreased number of embryo formation, decreased implantation rate, and increase the abortion rate. Increase ectopic rate also because of tubal distortion. Tubal function like motility and ovum pickup function, tubo-ovarian relation is disturbed because of some chemical problem, some inflammation. If you see the peritoneum, that intraperitoneal inflammation, cytokines, inflammation leads to problem in peritoneum function. And same time, the sperm, because when they enter in the vagina, cervix, because of endometriosis, there are lots of macrophages, and this leads to inactivation of the sperm function because of antibody present in the endometrium and luteal phase defect and implantation defects. So if you see the extrapelvic endometriosis, so again we have discussed if it is related to rectum, leads to cyclical rectal bleeding or hematuria, cyclical during period. If you see the scar endometriosis, then cyclically there is a pain in the scar. It will swell and go away. So that is a scar pain because of scar endometriosis. Sometimes umbilicus endometriosis cyclically leads to pain around umbilicus. And if you see the involvement of the pleura, pulmonary endometriosis leads to cyclical hemoptysis and hemothorax. Symptom again we have discussed like dysmenorrhea, dyspareunia, deep-seated pelvic pain, dysuria, dysphagia, hematuria, infertility. During clinical examination, PV, and there is a tenderness. Tenderness in cul-de-sac. There is a nodularity, typical nodularity in cul-de-sac. That is a rectovaginal septum involvement. Fixed retroverted uterus, tender uterus, adnexal tenderness, and adnexal mass. It is a sign if you carefully evaluate the endometriosis. Yes, best to diagnose is transvaginal sonography. Lots of modification, 2D sonography, 3D sonography, 4D live, color Doppler. If you do carefully transvaginal as well as the record per abdomen sonography, we can judge exact what is the situation of the uterus, endometrium, and the chocolate cyst, what is the sliding test, fixation because of retroverted uterus. So very rare we can diagnose by the sonography. Some cases with those who are with the adenomyotic uterus and we are puzzled with the any mass, some time we need MRI to rule out associate mass or to rule out some malignancy, how extent it is, whether it is involved in a rectovaginal septum or not. For that, we need to do MRI. But not routinely we are doing, but those cases are need operation. Before that, better to do MRI, extension of endometriosis, and to rule out any other pathology. Yes, color Doppler, increase vascularity. So by doing this, we can diagnose some early changes in endometrioma, sometimes thick wall, eye vascularity. We have experience, and after third surgery, there is a chocolate cyst. Patient is not ready for egg donation, and we have done color Doppler, and that we have suggested some may happen malignancy. Patient then turn out it's a malignancy of the ovary. So color Doppler has its own role. Again, when there is a hematuria or any problem related to urinary bladder, we can do cystoscopy. Mostly we are doing at the time of hysterectomy, when we are doing hysterectomy for the endometriosis. Again, sigmoidoscopy, when it's required, we can do it. Laparoscopy is the gold standard for the diagnosis. CA 125 is not for diagnostic but screening test. It increased with the moderate to severe, increase in the non-mucinous epithelial ovarian cancer. So it's not commonly used. If you see the images of the 2D sonography, we can do very well in ovary. This endometriosis, ground glass appearance. This is, we can see both ovary, right ovary, left ovary. This is kissing ovary, obliterated POD, and we can diagnose very well about the endometriosis. Again, transvaginal sonography, there is a fixed retroverted uterus because of adhesion. That is obliteration of POD in the second images. Again, this is vaginal post hysterectomy, we can see adherent rectum and thickened posterior vaginal fornix, so that we can diagnose any vaginal involvement of the endometriosis after hysterectomy very well by the transvaginal sonography evaluating endometrium wall. So sonography imaging, again, this is a right ovary, left ovary, chocolate cyst. So it's easy to diagnose, but small recurrence also we have to diagnose. We have to differentiate it with the ovarian cyst. We have to differentiate it with the hemorrhagic cyst. Because if hemorrhagic cyst, if you give progesterone therapy or any estrogen progesterone therapy, it will go away. Hemorrhagic cyst after 1 or 2 months, but ovarian cyst will not decrease. So you can give OC pill to differentiate hemorrhagic cyst from the chocolate cyst. Again, I have told about the MRI. In a few indicated cases, deeply infiltrated endometriosis, we can see uterus, endometrium very well, any involvement like adenomyotic uterus, any involvement in ovary, bladder, surrounding structure by MRI, and it will be helpful before the surgery. Laparoscopy, again, go very well, gold standard for the diagnosis and treatment. But if primary patients suffer from the pain in young age, whenever it is possible, try with the medical treatment. When the medical treatment fail, then you can do laparoscopy. As per pain is concerned, if DUB is concerned, normally it is not indicated for the diagnosis. Mostly for the hysterectomy, yes, laparoscopy is better. But infertility or pain, first try with the medical treatment. When it fails, then you can do laparoscopy. But in a laparoscopy, we have to understand when you are suspecting endometriosis, better to very thoroughly involve preparation before operation. Only Dulcolax will not work. Better to give Praglec to evacuate all the any bowel. So for a better visualization of all the lesion around the uterus, fallopian tube, ovary, and peritoneum. Better to have a experienced surgeon, experienced team. Anything we can diagnose during operation, we should able to tackle it. So best unit, best team, best experienced doctor, and we have all the need gadget to for the diagnosis as well as for the treatment also. So laparoscopy you are doing with the endometriosis, keep in mind if there is anything diagnosed, we can operate it at the same time. So diagnosis as well as operation in a laparoscopy. So detection of the lesion, if needed, we can take biopsy. If biopsy is positive, that is full proof of endometriosis. But if biopsy is negative, that cannot rule out the endometriosis. We have to see the symptoms by visual impression during laparoscopy. We can do staging and surgical treatment. Microscopic, if needed, we can do immunohistochemistry. Here, all the type of lesion, classical lesion, powder burn, gunshot lesion, dark brown nodules may consist of old hemorrhagic surrounding a fibrosis, scarring, maybe adherent with the ovarian broad ligament or posterior uterus and vagina, sigmoid colon. Septal lesion may be red, flame, red-like lesion, glandular excretions, white lesion, maybe white opacity, yellow peritoneal patch and cellular peritoneum, red lesion, red broad ligament, blue, black lesion, left broad ligament, brown lesion, yellow vision, vascular lesion. So all type of lesion we can see, we have to diagnose, we have to treat it by, so you can do cauterization of all the lesion. Again, endometrioma of the chocolate is very, very important. First is diagnosis. Chocolate cyst diagnosis. When you are operating, better counseling the patient, evaluate the ovarian reserve, and about the recurrence. And during operation, there may decrease ovarian reserve. Because we have to treat the chocolate cyst, ovarian endometrium. And we have to avoid recurrence also. So puncture and fulguration is not a solution. Evacuate all the cyst wall, whatever you can do, best way, without or minimum damage of the ovarian cortex, because we have to preserve the ovarian cortex for the infertility, for the fertility treatment. So you need expertization, cautery carefully, ovarian tissue. If required, you can do micro cautery. Whatever the adhesion around the broad ligament and pelvic side, you can do adhesiolysis. If there is superficial ovarian endometriosis, implant on ovary, you can do cauterization, or you can excise it if it is more in size or depth in size. This is very much interesting, deep infiltrating endometriosis. It's not easy to do operative surgery on deep infiltrating endometriosis because it's a recto-vaginal septum is involved, deep 5 centimeter below the peritoneum. And it involves uterosacral ligament or bowel and ureter. Required expert team, many good gadget like 3D, 4K, and assess the ureter and kidney also if there is hydronephrosis or not. Then you can go ahead. Even we are doing excessive surgery, explain about the re-adhesion, reaping is important, and tenderness nodularity during the clinical examination is very important. Or you can do prerectal examination if there is a rectovaginal nodules. So before operation, thorough assessment is important. Counseling is very important. During operation, expert team is very important to do deep infiltrating endometriosis. Again, there is a lots of variety of endometriosis in GI, in appendix, rectum, or maybe cyclical pain. So we have to treat it thoroughly. In same way, hematuria, dysuria, or frequency of urine maybe involve ureter, maybe involve lower ureter tract. So before doing, do best of the best sonography about the kidney. Any hydronephrosis, if needed, you can do MRI. What is the involvement of the lower ureter? And then explain about the what we will do. If it is more obstruction, you may need implant, even builder. So implant. So hydronephrosis is very important. We have one interesting cases because of secondary recurrence. There is a big endometrioma, and there is the involvement of the lower ureter, and there is a hydronephrosis. So we have counseled a lot. We have treated with the operative on the ureter carefully. We relieve the obstruction, constriction, and then relieve of ureteric obstruction, and there is a relief of hydronephrosis. And we have done IVF, and it was successful pregnancy. So it's very, very important to diagnose and counsel the patient and treat the patient. Again, scar endometriosis, whatever the lesion, we have to excise thoroughly. And maybe in a cesarean scar or episiotomy, very, very painful, but it is treatable. Same vaginal endometriosis, posterior fornix, we can treat it. Thoracis, again, we can treat it by surgery. So what is the staging? Lots of discussion about the staging, minimal, mild, moderate, severe, grade 1, grade 2, grade 3, grade 4. It's involvement in the peritoneum, involvement of the posterior to the uterus, maybe involvement with the ovary, maybe involvement with the fallopian tube, with the adhesion, maybe flimsy adhesion, dense adhesion, maybe first time, maybe second time, maybe third time recurrence. So all type of required grade. So simply it's a minimal or mild or moderate or severe, depending on it's a where it is involved. So again, classification, depending on the involvement, depending on the adhesion, flimsy or dense adhesion, whether it is superficial, whether it is deep, whether it is involved only in peritoneum, whether it is involved ovary or whether it is involved in the deep septum. So all we have to mark it, and depending on the that's all number we can diagnose whether it is mild, moderate, severe, or recurrence. So we're not going in much detail. We already discussed about why there is an infertility because of distortion of pelvic anatomy. Severe adhesion will impede the egg release, will block the sperm entry in fallopian tube and inhibit the ovum pickup. Maybe other mechanism as well, anovulation, immunodysfunction, corpus luteum insufficiency, luteal weight defect. There is a decreased embryo quality, sperm quality because of toxicity in peritoneal fluid. That leads to infertility. Now part of treatment, it's not smooth ride. So if you see the simply oral medicine, analgesic you can give because of pain, may need oral, may have to combine with any higher analgesic. Sometime we have seen a young lady, dysmenorrhea, not really by oral, they are taking injectable, diclofenac injectable, sometimes vomiting, they will come in emergency. We have seen one patient, young lady, 19-year medical student, 5 times she came with the ambulance because of severe pain. So that pain we have to understand, we have to give some analgesic, but we avoid the second, third cycle pain. We can give some progesterone or combine OCP. If you see the combined OCP, the gold standard as per oral medicine is concerned, better to give continuously, pseudo pregnancy like treatment. Initially, they may have side effect, but you have to see what is the status of the hypercoagulation. Rarely we have seen 1 or 2 young lady or adults in a reproductive age when they are taking OC pill for 7 to 8 months. We have seen thrombosis of the brain, even intestinal thrombosis. So be careful prescribing estrogen because it's a thrombogenic hypercoagulation it helps. So, but this is a gold standard OC pill whenever it is suitable. Base treatment we can give for 3 to 4 months continuously without period, and she will be much comfortable, and slowly lesion will subside, pain will subside. But tolerance is the main part. So depending on the weight, tolerance, and patient profile, we can give continuous OC pill in a selected cases. Now let's say progesterone is available, anti-progesteronic effect continuously we have to give. There is a deterioration because of progesterone. There is atrophy of the endometrium. Slowly pain will subside, lesion will subside. We can give norethistron up to 10 milligram, 20 milligram daily. Dydrogesterone 10 to, if we need higher dose, 30 milligram daily for the endometriosis. And Dynogest is also available. Slowly, continuously. Initially, there is a maybe spotting, but after 3-4 months, there is a amenorrhea. We can give for 1 year, 2 year, even in adolescent. Those who are not willing for surgery, and patient will comfortable with the any Dynogest oral tablet. So hormones we can give if it is well tolerated. After 2 or 3 years, maybe side effect like slowly weight gain. Maybe we have to watch for the bone mass density. If you are giving for long term, even if only progesterone leads to decrease bone mass. So may need add back therapy with the estrogen. Again, denazole is a very effective anti-androgenic, but side effect is too much because of hirsutism. There is a change in voice, there is a increased weight, and atrophy of the breast and vagina. That is a main side effect, but very effective. In short period for 1 or 2 months, we can give initially with the low dose, 200 milligram. You can increase up to 400, 600, 800 if it is tolerated. So denazole previously we are using, but if you see in the X-ray guideline, they have not included denazole in the X-ray guideline as per endometriosis treatment is concerned. But previously we are giving denazole, but we have to counsel the patient about the side effect. Letrozole is very well tolerated, anti-estrogenic, because this endometriosis is dependent on estrogen. So logically, we can give aromatase inhibitor, decrease in estrogen level. That will decrease the lesion and pain, and that is all the pain will subside with the letrozole. So after it's prevent the conversion of androgen to estrogen. Again, we have discussed about Dynogest. Yes, Mirena. This is a progesterone contained intrauterine levonorgestrel containing intrauterine device. So slowly release of progesterone, slowly it will relieve the symptoms of the endometriosis, pain, and it is mainly for endometriosis. So when you have tried with the oral medicine, maybe progesterone, maybe OC pill, if it not relieve, we can do Mirena insertion if patient is not willing for surgery. If patient is not willing for the injectable GnRH analog, very good result once it should. Follow-up is very important. It will last for 5 years, mainly for DUB, Mirena. But yes, in a very few selected cases, we can put Mirena because in IVF we need some time in adenomyotic uterus, repeated pregnancy loss, 5 loss, 6 loss, uterus is too much adenomyotic uterus. In that case, we have used Mirena under GA after dilatation, do DNC, rule out any malignancy, and you can put Mirena and counsel the patient about the follow-up, and 2-3% is expulsion rate. Otherwise, it's good if you are for the long-term follow-up. If your endometriosis is for or adenomyotic uterus and Mirena is for IVF for infertility, you can cap for 6 months. After 6 months, you can remove it, wait for 1 or 2 months, you can transfer embryo after 2 months. Effective Dynogest in endometriosis, we have already discussed, very well tolerated and good medicine. Again, GnRH analog master drug, GnRH analog depot we can give. Effect is lasting for 25 to 30 days. It suppress the and down medical menopause. Suppress FHH, LH, suppress the estrogen and progesterone production. It will do atrophy of the endometrial tissue, relieve the pain, and you can repeat after 1 month. 3.75 milligram is available depot form. Every month you can give, or 11.25 intramuscular you can give, and effect is for 60 to 70 days depot. So it's very well effective. Prolonged GnRH therapy we can give up to 6 months before for the adenomyotic uterus, for the endometriosis pain. But after 3 months, you may need some adback therapy. We avoid hot flushes or hypoestrogenic effect, menopause-like symptom, by giving low dose of estrogen in a selected cases. RU486 anti-progesterone, we can give 25 to 50 milligram daily for 3 months to reduce the pain and delay the recurrence. Again, laparoscopy is gold standard for the in the indicated cases. Advanced stage of disease detected, large lesion, medical therapy failed, recurrence is there, elderly parents, women required surgery by 3D, by HD, by 4K, and by robotic surgery. There were lots of advancement of laparoscopic surgery. And now surgeon is also competent to deal all the variety of endometriosis assessment and cure the disease, remove the endometrial implant, whatever is possible. And our aim is to restore the anatomy. Better visualization, precise cauterization, and decrease the ovarian damage. That is our principle in 3D endoscopy. We have many cases all the time, and all extensive endometriosis, recurrence of endometriosis before IVF, and we are doing surgery by our team 3D endoscopy, and almost we can minimize the damage, minimize the ovarian the damage, and we can control the ovarian reserve, and blood loss also we can decrease. So the recovery will be better. What is our aim in surgery? To reduce the pain, to increase the possibility of pregnancy, to delay the recurrence as much as possible. Better visualization, less tissue trauma, smaller incisions, speeded post-operative recovery, less post-operative adhesion, less cost, result are equivalent to or better than laparotomy. Elevate the pain, removal of endometrium for the histological diagnosis without risk of multiple pregnancy, possibility of achieving subsequent pregnancy. Decrease inflammation in pelvis, decrease toxicity of embryo and gamete, enhance uterine receptivity, restore anatomy, tubo-ovarian relation will be re-established, and restore the spontaneous ovulation. That is the advantage of laparoscopy. What is the principal surgical treatment if it is less than 2 mm implant? Treat by vaporization, coagulation, and excision. Electrocautery cutting current, you can set around 40-60 watt, or laser you can do. This method especially useful when endometric foci are close to ureter, great vessels, bladder, and intestine. Implant size 2 to 4 mm may be treated by vaporization or excision. More than 4 mm require deep vaporization and advanced excision technique. Here you can see fiber optic ureter implant. Whenever you are suspecting ureter damage, or there is a hydronephrosis and ureter, lower ureter is involved, you can do fiber optic ureteric catheterization before the surgery to avoid any damage to the lower ureter. Again, laparoscopic endometrium cyst removal carefully. All we can do cystectomy, because we have to remove the all the cyst wall. Don't do drainage and coagulation because it create more problem, more adhesion, and surgery is very difficult. So cyst wall excision is the best treatment as per endometrium is concerned. Expert surgeon is required. Micro coagulation you can do to minimize the ovarian cortex, because it's low risk of destroying ovarian cortex by stripping and thermal damage. Few reports suggest reducing ovarian reserve and subfertility following hysterectomy. Rectovaginal nodule, lesion on the surface of the rectum, superficial lesion, maybe deep infiltrative lesion. Excise it and primary closure. Again, deep filtration, deep rectovaginal nodules, carefully we have to remove to have by minimum damage to the uterus, or you can evaluate the rectum, any damage. Then if we there by fault any damage, early recognition, early repair of the rectum is required. We have seen end-to-end anastomosis even in case of rectum involvement. We have done cyst bladder wall involvement. We have seen removal of the bladder wall and end-to-end closure in case of bladder involvement. So this is all, if there is advanced case of endometriosis, we can treat it. We have seen also cases, they are primarily tried with the, mainly in hysterectomy. They have tried vaginally, not possible. They tried with the laparoscopy because of severe adhesion or sometimes associated fibroid, PID, endometriosis, and some mass in leads to frozen pelvis. So in that case, thoroughly evaluation before the surgery is required. Counsel is important. Our team is ready to tackle any problem related to uterus during removal of the uterus, and any problem related to ureter or bladder. Your team should be ready, or your GI friend or your urologist should be ready to tackle any problem. And sometimes extensive surgery may need vascular surgeon also to inform. Keep blood ready, then you can tackle very well to avoid any complication, any recurrence. Whatever you can do best for the patient, do it. What is the basic problem of that patient, better to treat it in this one sitting. So whenever needed, surgery is very useful to avoid the adhesion. Maybe some interseed is available, that is oxidized regenerated cellulose. One package of 3 to 4-inch fabric or adhesion or tissue without foam gel within 8 hours after application is applied. Degrade the glucose and glucuric acid within 3 to 10 days. So that is interseed is available to avoid the any recurrence. What about the debate about the pre-treatment of GnRH analog or treatment, then surgery? After surgery, whether we have to give GnRH analog or any progesterone or not. So all depend on the situation. If patient came for the pain, then trial with the oral medicine, not relieve, then do surgery. If patient is for surgery or infertility, no need of any preoperative treatment. Go for surgery. Any patient do best of the best treatment, remove the pathology and wait for 1 month. Then next month you can do infertility treatment without giving GnR and NHO, without giving any digest or nothing. You first one. Don't wait. Don't waste the time. The second or third month or 4th month. Don't give any ovulation suppressing drug after surgery if patient is for infertility. So you can plan for the aggressive treatment because there is a chance of recurrence. Give 6 to 8 months to the patient if it is infertility. Who can't cook, they need treatment. Maybe simple treatment, maybe IUI or maybe IVF. Patients should conceive within 8 to 10 months to avoid any recurrence because recurrence is very worst. Your ovarian reserve will decrease. Because of adenomyotic, your implantation rate will decrease implantation rate and abortion rate will increase. So whenever you are doing surgery, counsel a lot patient about the surgery, about the recurrence, about after simple treatment, what will be the effective. If it is not effective within 6 to 8, do IVF and give the result to avoid any recurrence. If patient is for pakka case of surgery, then no need of any preoperative medical treatment. Go straight forward for the surgery because the pre-treatment like analog will mesh up the plane of dissection. It will become more difficult to dissect. So better to avoid any pre-treatment if it's the pakka case of surgery. So your team will able to do any damn problem in a endometriosis related to uterus, related to pain, related to infertility. Only shrink some type of endometriosis which are estrogen sensitive. Side effect of medicine or therapy is more fluid retention, irregular spotting, irregular uterine bleeding, weight gain, water retention, breast tenderness, headache, nausea, mood changes, particularly depression. Medical treatment, surgical fail to arrest disease in up to a third. Combination of treatment have also failed to control disease for indefinite period when follow-up. There is no cure of endometriosis. What is primary goal? To delay or stop the proliferation of endometrial cells to prevent the associated pain like dysmenorrhea and dysphoria. Secondary goal is to preserve and restore the fertility, to reduce the emotional distress and improve the quality of life. That should be the goal. We have study of the Endotone, that is a prospective, open-label, non-randomized clinical trial to evaluate the safety and efficacy of Endotone polyherbal capsule in treatment of endometriosis. Main object of study was to evaluate clinical efficacy Endotone for pain, dysmenorrhea associated with endometriosis. And further, the study also observed clinical safety of the endometriosis, Endotone in endometriosis. A non-randomized phase 4 prospective open-label clinical trial in women diagnosis endometriosis of any grade who plan following required GCP guideline. To women were included in the study diagnosed with endometriosis of any grade classification by revised American Fertility Society in 1985. Patients were recruited between December 22 to October 23. Institutional Ethical Committee approved this clinical trial was obtained before starting the study. Patient visited outside the Department of Gynecology, diagnosed by the attended gynecologist with endometriosis, who may undergo any radioimaging confirmatory diagnostic procedure or having previously undergone laparoscopy for the same were included. So it's a pakka case of endometriosis by sonography, by laparoscopy. So women below the age of 45 and above the age of 18 were included. Experienced endometriosis symptoms like pelvic pain, dysmenorrhea or dyspareunia. Documented diagnosis of endometriosis were included. What is the exclusion criteria? Those who are suffering from chronic pain and not caused by endometriosis. Patient taking any concomitant hormonal treatment, including OCP. Known systemic disease like hypertension, diabetic, coronary, renal, hepatic, or large chocolate cyst or malignancy. Menopause women, pregnant or lactating women are excluded. After careful selection in terms of eligibility criteria, screen subject willing to enroll the explaining clinical study procedure, patient consent were obtained. Everything we have counseled about the study. And ethical committee have approved this study in Sunflower Hospital and enrolled the subject for the study. Capsule endotone given 2 capsule morning, 2 capsule in evening after meal, and was started from the 5th day of the menstrual cycle and given for 3 months. So this is the composition of endotone. The endotone people will tell you about all the content, and we have follow up with the what is the relief of pain and evaluated baseline on the 1st month, 3rd month, and 6th month after the onset of treatment. Efficacy of measured in term of reduction in pain. We have used VAS score for pain about the dysmenorrhea and dysmenorrhea associated with the endometriosis. And at the same time, how they relieve the pain, how they will improve their quality of life, we have assessed by the VAS score. Permitted rescue medication if required to reduce the embarrassment, abdomen pain, including the NSAID drug, which required what they have. So dermographic and vital about the age, weight, height, pulse, BMI, all 50 cases we have included about dermography and vital signs. The age between 20 to 43, weight between 37 to 88, weight 149 to 168, pulse, BMI, SBI, and DNP. Same way, we have see the reduction in pain baseline after 1st month, after 3 months, after 6 months. So there is a mean pelvic pain we reduced from 6.54 before the treatment, which was significantly reduced to 5.18 after treatment at 6 months from the baseline, which is significant. So endotone treatment significantly reduced the mean dysmenorrhea from 6.8 to 5.3 with a simple treatment, 6 months, very well tolerated, no much side effect, and not so much costly again. Pelvic pain reduced the pain from 6.54 to 5.18. Dysmenorrhea reduced from 6.83 to 5.32. Dyspareunia reduced from 5.90 to 4.80. Consumption of analgesic reduced 46% in patient, and quality of life improved by 40%. Exhibit good clinical global impression in efficacy and tolerated by both physician and patients. Endotone is effective in symptom of endometriosis like dysmenorrhea, dyspareunia, and pelvic pain. When patient does not want to go for the hormonal treatment, have to have side effect or hormonal treatment, then endotone is drug of choice. Even after surgery for endometriosis to reduce the recurrence, we have given capsule endotone. So conclusion of my study is polyherbal formula is effective and safe and cost effective in controlling the sign and symptom of the endometriosis, which is now all the gadget is available. In comparison to this, endotone is very effective, cheap, and safe. So what we have done in our sunflower, our IVF success rate, you can see the pregnancy rate per embryo transfer is around 75%. Fresh shelf, even 73%, self OD 77%. So our team have done lots of work at sonography, endoscopy, embryology, clinician doing hard work and giving good outcome for the IVF as per is concerned. We have so many patients from outside Gujarat also, outside India also, from UK, from Canada, USA, Australia, and we are happy to have them all complicated cases, multiple failure, even azoospermia, we are doing microtessay and we are giving good result. And thank you very much for the patient hearing.
Thank you so much, sir. Now, colleagues will move ahead towards our second session, which will be taken by Dr. Milind Patel, MD Ayurved and Head of the Medical Department at Charak Pharma. He will cover the topic role of phytomedicines in endometriosis. Over to you, Dr. Patel.
Good afternoon, friends. Thank you, Dr. Patelji, for your wonderful, elaborate, and detailed talk on endometriosis.
Thank you.
Yeah. Can you hear me, Doctor?
Yes, yes.
So, taking from you, I will take further this. I will talk about the modes of mechanisms of endotone in endometriosis. So, my title of the presentation is Phytomedicines in Endometriosis. Taking further from all modern medical treatment, I will talk about the role of herbs, the role of phytomedicines, the role of Ayurveda in the treatment of endometriosis. So, as the doctor rightly said, the pathophysiology of endometriosis, there are certain factors like inflammation, oxidative stress, adhesion and invasion, angiogenesis, apoptosis, and circadian dysregulation. So when I think of role of phytomedicines in treating endometriosis, I would like to tell you that herbs of endometriosis, endotone capsule do have anti-inflammatory activity, antioxidant activity, anti-adhesive. So whatever pathophysiological factors are involved in endometriosis, they are particularly dealt well with the endotone ingredients. So let me take you through my presentation. As Dr. rightly said, that the goals of therapy in endometriosis are, we can divide them into primary goals to delay or stop the proliferation of endometrial cells, to prevent the associated pain like dyspareunia and dysmenorrhea. Secondary goals are to preserve and restore the fertility and to reduce the emotional stress and improve quality of life. Secondary goals are too important to be considered as the goals of endometriosis therapy. Primary goals are, of course, they are primary goals. So we must make sure that we give relief by giving certain phyto. So today is IVF day. There is some analysis of this, some study analysis of IVF XA outcomes in endometriosis. it says that it is necessary to identify and control the activity of endometriosis so that endometriosis patients may benefit from and achieve successful clinical outcomes with IVF ICSI treatments. So it is very important that we discuss the importance of endometriosis awareness and also the various medicines that are available. Just try to understand. This is one publication. The title is Endometriosis and the Herbal Medicine Approach to Treatment. So if I want to talk about the ingredients action, herbal action, there are various categories like aromatase inhibitors, progesterone support, anti-proliferative, uterine tonic, emmenagogues, spasmolysis, and immune regulation, antioxidants, anti-angiogenesis, lymphatic drainage, and anti-adhesive. If you look at this herbal action, modes of action of endotone ingredients, we find that there are certain ingredients in endotone which do have these activities: cinnamon, glycyrrhiza, vitex, and if I take your attention to curcuma longa, role of curcuma longa in the treatment of endometriosis is very critical because it is really a multifaceted medicine for women, as Ayurveda describes it as beloved of women. So curcuma is here regulation, curcuma antioxidant, curcuma anti-angiogenesis, curcuma anti-adhesive. So majority, in fact, endotone addresses all the pathophysiological features of endometriosis. I will share some of the references. Curcuma longa is haldi. In Sanskrit, it is called as haridra. These are the modes of actions or benefits of curcuma longa. It downregulates inflammation and oxidative stress in endometriosis. It directly acts on invasion, adhesion, apoptosis, and angiogenesis in endometrial lesions. It reduces the number of endometriotic stromal cells and slows down the progression of the cell growth. It lowers estradiol, which is important in ectopic endometrium, delays endometriosis development by inhibiting matrix metalloproteinase 9. Now, these are based on certain published scientific published literature dated on 2020, 2013, and 2012. So friends, when I say that in Ayurveda, haldi or curcuma longa is described as beloved of women because of all these actions, modes of mechanisms, which do really address all pathophysiological features of endometriosis. Again, if I talk about curcuma longa, there are certain modes of action: anti-proliferative, anti-angiogenic, apoptosis, anti-inflammatory, and it does have a significant in vitro anti-angiogenic activity for endometriosis treatment. This is again published in latest article published in 2024. So we are pretty sure that the herbal medicine is the future medicine because of the publications that are happening in the journal, scientific journals. This is as recent as 2024, which talks about the role of haldi, curcuma longa in the treatment of endometriosis. Similarly, there are certain ingredients: Lodra or Simplococcus racemosa, anti-androgenic, HPO axis modulator, and insulin sensitizer. It promotes fertility, it prevents ovarian cell failure, it restores estrogen and progesterone levels. So all these activities are really required in the treatment of endometriosis. Ashwagandha or Vidania somnifera. Modes of mechanisms as given in 2019 article. It has anti-inflammatory activity. It regresses the lesions and restores the natural architecture. It reduces the spherical volume of ectouterine tissue. Again, Vitania somnifera is described as adaptogenesis. Friends, you must realize the patient of endometriosis undergoing huge lot of mental stress. quality of life is totally depressed, bad. And that is where adaptogenic property of Vidania somnifera will help us give immense relief to endometriosis patient. It has anti-cancer activities too. I talked about the adaptogenic nature. It stimulates adaptive humoral cellular immunity. It is again an immunostimulant to support immune response in endometriosis. This is, I'm talking from the available references in modern scientific journals. Glycyrrhiza glabra, phytoestrogen, is found to inhibit estrogen-mediated tumorigenesis. Tumorigenesis is very, very similar to tumor is very, very similar to endometriosis lesions. Cytotoxic activity could potentially serve as chemoprotective agent, and major chemical may have ability to treat endometriosis. Again, published in latest journal in 2023. Centella asiatica is a nootropic, neuroprotective, cerebral antioxidant, cognitive enhancer. It modulates neurotransmitters. It is nootropic and it is a mood stabilizer. The endometriosis patient is very, very depressed and under tremendous mental stress, and that is where Centella asiatica or Brahmi will be of use. Then Cinnamomum cassia. Again, it inhibits self-viability, invasion, glycolysis in primary endometrial stromal cells. The point that I'm driving is that all ingredients of endotone have been tested and found to be effective in particular disease of women, that is endometriosis. Gingiber officinal, it has anti-inflammatory action. It inhibits endometriosis by down-regulating and inflammatory markers like nuclear factor kappa B, etc., etc. It reduction in implant size and histological changes in endometrial lesions. So friends, the ingredients of endotone do have a specific mechanism of action which lead to overall relief in endometriosis. And as doctor did really elaborate on the clinical trial that he himself led, that he established the efficacy and safety of endotone in endometriosis, we can call it as India's #1 natural management of endometriosis. These are the ingredients like Cyperus rotundus, Curcuma longa, Symplochus racemosa, Withania somnifera, Glycyrrhiza glabra. There are 8 ingredients, and as you rightly observed in the article that I showed you, that these ingredients are mentioned in modern published literature where it talks about the effect of these herbs in endometriosis, identifies the modes of mechanisms. Just see, in endometriosis, we require anti-proliferative, anti-nociceptive, anti-inflammatory, fertility enhancer, adaptogen, and antioxidant medicines. And this is how the ingredients offer us those properties. Musta, anti-proliferative, anti-nociceptive, anti-inflammatory, antioxidant. Haridra, anti-proliferative, anti-inflammatory, antioxidant. Lodra, you can look at the pluses, anti-inflammatory, predominant activity of all endotone ingredients. They do have anti-nociceptive, anti-proliferative, fertility enhancer activity. They are adaptogens as well, and they do have a potent antioxidant activity. So all the ingredients of endotone do have anti-inflammatory, antioxidant, and necessary activities for the treatment of endometriosis. This is very clear from this slide. And therefore, the treatment, the clinical trial, which was done by Dr. R.G. Patel himself, shows the results of clinical trial in reducing pelvic pain, in reducing dysmenorrhea, dyspareunia, consumption of analgesics is substantially reduced, quality of life improves. So endotone in the clinical trial exhibited good clinical global impression in efficacy and tolerability. by both physicians and pathogens. Probability value was less than 0.01. That itself suggests that endotone is the right remedy for the management of endometriosis. It is clinically effective and safe in endometriosis. So endotone does meet treatment goals for endometriosis. That is what we can certainly say, because the treatment goals like to delay or stop the proliferation of endometrial cells, curcuma longa and Cyperus rotundus, to improve the hormonal balance, we have Symplecus racemosa, to prevent the associated dysmenorrhea, dyspareunia, we have Cyperus rotundus, gingiber officinale, Cinnamomum simplicus racemosus. There are certain anti-inflammatory medicines like curcuma longa, Cyperus rotundus, gingiber officinale, Simplecus racemosa, Withania somnifera. It does preserve the fertility, Cinnamomum cassia, to reduce the emotional distress and improve quality. This is very important goal for the treatment of endometriosis. Gingiber officinale, Withania somnifera, and Glycyrrhiza glabra will help us reduce the emotional distress and improve the quality of life in endometriosis patients. So Endotone is India's first natural management of endometriosis because it does reduce the need for surgery in endometriosis. It reduces the pain associated with dysmenorrhea. It corrects estrogenic insufficiency, improves ovarian functions and fertility. This is very important. And the one I will take the liberty to add, it does reduce the recurrence rates of endometriosis. Dosage recommended is 2 tablets 2 times a day for 6 to 9 months. Thank you, friends, for your attention. Thank you, Dr. Patel ji. Namaskar.
Sir, we have a lot of queries.
Over to
from
Dr.
delegates.
Nikhil.
Yeah. Sir, we have a lot of queries from our delegates. So I'd like to go one by one. We'll take a few queries. This query is from Dr. Nanda Devi, who belongs from Thiruvananthapuram, and she wants to ask Dr. R.G. Patel that whether he has noticed any increased incidence of endometriosis in RA positive patients.
Just can you repeat the question?
Yeah. Sir, have you noticed
Okay.
any
RA
increased
factor, yes, yes. This is
Yeah.
a like autoimmune disease. So any autoimmune disease like a rheumatoid arthritis, celiac disease can be associated. But it all case of rheumatoid arthritis will increase the endometriosis, but can be associated with this autoimmune disease. Because what happen in endometriosis, there is a decreased phagocytosis of the natural killer cells. Clearance of the all the endometric cell will not clear by in some patient, and that leads to endometriosis. So yes, in rheumatoid arthritis is also an autoimmune disease. This endometriosis is also endometriosis can exist in between. Yes.
So the next question is from Dr. Avni. She is asking, can regular use of menstrual cup cause endometriosis? I'll repeat the question. Can regular use of menstrual cup cause
Oh, yes,
endometriosis?
yes, yes. Yes. We have to understand very well. I think any small obstruction can lead to problem. We know any anatomical obstruction, septum, stenosis, obstruction in vagina, congenitally in young adolescent, and they are coming for this endometriosis. So vaginal cup is also one short of little obstruction. So we can think there may be one of the reason. So those who have family history or only suffering from endometriosis, better to avoid it.
So it means we need to take care with all the menstrual hygiene practices and not
Yes.
only the menstrual cup. Yeah. Next question is for Dr. Milind Patil. Dr. Varsha from Nanded. She is asking what is the Ayurvedic approach to endometriosis and which univapor is correlated with endometriosis. Over to you, Dr. Patil, sir.
Yeah. Good question from doctor. Okay. Dr. Patel did mention something about retrograde menstruation. Now, Dr. Varsha, if we think of Ayurveda nomenclature of endometriosis, we have 20 different univapors described in Charak Samhita, and there one univapor is particularly described as, the name is Udavartini univapar. The moment you hear the word Udavartini and relate it to retrograde menstruation, things are very crystal clear. So you can very safely consider Udavartini univapar as endometriosis. And the treatment of univapar is Vatashamak and etc. etc. They do have their activity on Tridoshas and Samprapti Bhed. So we can think of treatment of Udavartini as endotone Ayurvedically.
Thank you, sir.
So Dr. Nikhil, one needs to understand endometriosis from Ayurvedic viewpoint as Udavartini univapar.
Thank you. Next question is from Dr. Preeti from Hyderabad. She wants to ask this question to Dr. R.G. Patel. What are the chances of conception in endometriosis patient and the need of preconceptional care in those patients?
Yeah, because we have described because of endometriosis, there is a anatomical problem in the fallopian tube, adhesion, tubo-ovarian relation are disturbed, ovulation is disturbed, corpus luteum function is disturbed. So we have to assess the patient. If there is endometriosis, we cannot do routine we cannot wait, but we have to do something little aggressive about the ovulation induction, about the intrauterine insemination, try 1 or 2 or 3 IUI, not to go for 6 IUI. If needed, you can do a surgical treatment. And after even surgical treatment, our aim is to restore the anatomy, whatever the causative factors or endometrium implant, endometrioma or adhesion is there, we have to clear thoroughly and nicely without damaging fimbria, ovarian reserve, fallopian tube, and thorough hemostasis is required. Because if there is a blood collection after surgery, it will create the adhesion and tubo-ovarian disturb. So after surgery, even you can don't give any progesterone, leupride, depot or suppressive, ovulation suppressive treatment. After second month, third month, you can try expected management. Start with the ovulation induction and plant relation in the third month. Fourth month, you can try with the IUI, with the letrozole, with gonadotropin. Not conceive, only gonadotropin and IUI, and not conceive and start with the IVF. Don't wait more than 6 to 8 months. That should be the protocol for the little aggressive, not too much, not too much, but little aggressive protocol, because here chances of recurrence is there, chances of natural conception is little less. This is not normal anatomy. So this is little disturbed anatomy, disturbed pathology inside the ovulation and conceive rate. So go for thorough assessment, counsel the patient, and do little aggressive for the treatment is concerned.
Okay, sir. Next question, so, is from Dr. Anup, who belongs from Varanasi. Uh, he wants to ask, can thyroid dysfunction trigger endometriosis?
Yeah, thyroid dysfunction can associate with the endometriosis, but both are little different entity. But incidence of thyroid in endometriosis little higher side. So in endometriosis case is there, we should thoroughly investigate about the hormonal problem. Like ovarian function, we have to do anti-Mullerian hormone. We have to do thoroughly sonography about the ovarian volume and AFC. At the same time, we have to see the thyroid also and the prolactin also. If there is rearrangement in the endocrine, or better to do normalize the endocrine, that will improve your IVF result.
One query is from Dr. Pitambar. Jodhpur. We already discussed about CA 120, but he wants to ask, can we diagnose endometriosis by any other blood investigations?
No. No any other blood test or AG for the diagnosis. CA 125 is not for diagnosis. It happened in a severe to moderate endometriosis. It is not for to rule out the endometriosis, but for prognosis, how it fall after surgery, after suppression. What is the fall in CA 125? We can judge how your treatment is little effective. Otherwise, it is not for any diagnostic. Yes, but sometime borderline cases of ovarian mass or when you are suspecting malignancy, so with CA 125, with color Doppler, with sonography, with other color tumor marker, CEA and or other tumor marker LDH, you can diagnose for the malignancy. But for endometriosis, you need not help for the diagnosis.
In relation to the same thing, Dr. Manoj from Alwar wants to ask, what is the incidence of cancer due to endometriosis?
Yeah, we have seen one cases, patient was 2-3 IVF fail, and we have done color Doppler. There was a thick wall and color Doppler showing high slow resistance, and we are suspecting malignancy. And it turned out to be malignancy. But if you see the data, the chances of endometriosis cancer is little on higher side. Even in endometriosis, there is a high chance of like thyroid, like autoimmune disease, like diabetic, blood pressure, even MI, and all malignancy will be little on higher side in endometriosis because of all autoimmune disease. Yes, chances of malignancy is little on higher side.
Last question is, what is the recommended dose and duration for endotone capsules?
It's a 2 capsule in morning, 2 capsule in evening for 6 to 9 months.
Okay.
And it is very well tolerated. We have not seen any side effect of the endotone.
Thank you, sir. We have still a lot of queries, but considering the time constraint, we will answer them directly via the contact details which are being shared during the registration.
My pleasure.
Yeah. With this, we would end our session. I would, on behalf of Charak Pharma, extend our heartfelt gratitude to each and every one of you for joining us today for this enlightening endometriosis awareness program. It has been an enriching experience filled with valuable insights and discussions on endometriosis. First and foremost, I would like to express our deepest appreciation to our distinguished speakers, Dr. R.G. Patel sir and Dr. Milind Patil sir. Thank you for your illuminating presentations, which have expanded our understanding and provided us with practical knowledge in endometriosis. Your expertise and dedication to advancing medical knowledge are truly commendable. I'd also like to thank all the participants who actively engaged in the discussion. Your thoughtful questions have enhanced the depth of our exploration into endometriosis. A special word of thanks goes to the organizing team and technical staff who worked tirelessly behind the scene to ensure the smooth conduct of this webinar. As we conduct this webinar, let us carry forward, as we conclude this webinar, let us carry forward the knowledge gained today and continue to collaborate in advancing medical research and patient care. Thank you, sir.
Thank you.
Thank you, doctor. Thank you, doctor. Thank you, Dr. Nikhil.